Hello, everyone. Thank you for attending today's webinar, Digital Solution for Antimicrobial Stewardship Program, presented by Roche and Innovacer. I'm Liz Wesky, and I'll be moderating this webinar. Our speakers today are Dr. Soham Shah, MD, MBA, CPE, FACP, Value Delivery and Implementation Science of Roche Information. Dr. Stephen D. Burdett, MD, FIDSA, Medical Director of the Antimicrobial Stewardship Miami Valley Hospital and Premier Health, 2019 IDSA Center of Excellence. Dr. Brian Lee, MD, FAAP, Director of Clinical Development of Roche Diagnostic Solutions. Jean M. Nelson, Senior Business Product Manager, Clinical Care Solutions of Roche Information Solutions. And Alan Antoine, AVP, Clinical Innovation, Clinical Care Solutions, and Pharmacy Innovation of Innovacer. You can read their full bios on the left side of your window by selecting the Speakers tab. Just a few technical notes before we begin. The webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please ensure that your volume is all the way turned up. This webinar is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentations with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. Okay, now let's begin. Soham, please go ahead.
Hello, everybody. At Roche, we are excited to unleash the full potential of digital solutions. We are striving for a more connected, secure, efficient, and agile healthcare system where digital technologies unlock new possibilities for better care. These are our guiding principles in the development of our Navify portfolio of digital health solutions. Now we'll go with some questions with our panel of experts. Dr. Burdett and Dr. Lee, would you like to tell us a bit about yourself and your background?
My name is Steve Burdett. I'm an infectious disease physician here in Dayton, Ohio. I'm the Chief of Infectious Diseases for Wright State University Boonshoff School of Medicine. And here at the hospital that I work at, Miami Valley Hospital, I oversee both the infection prevention as well as the antimicrobial stewardship programs.
Great. And Dr. Lee?
Hi, everyone. I'm Brian Lee, and I'm Director of Clinical Development at Roche Diagnostics. My background is in pediatric infectious diseases, and prior to Roche, I had founded and ran an antimicrobial stewardship program at UCSF Benioff Children's Hospital in Oakland. And so I have a passion for stewardship and addressing antimicrobial resistance.
Perfect. Thank you both. Dr. Burdett, if I may start with you, what are some of the core elements of a hospital antimicrobial stewardship program?
Yeah, so around 2014, the CDC did put out 7 core elements that antimicrobial stewardship programs should follow. And just moving through those real quickly, one of those is hospital leadership accountability. So coming from the C-suite, they have to provide both physical resources as well as financial resources for a pharmacy, for the physicians to put together a program to help control antimicrobial use. Stewardship programs have to be accountable. So what we say we're going to do, the metrics that we're going to put together, we have to follow through on those processes. You have to have pharmacy experience. Antimicrobial stewardship is not just a physician-led thing. It really is a collaboration between the pharmacists and the physicians. Each one brings their own unique set of skills to the table. And so you have to have a dedicated, either single pharmacist or a dedicated pharmacy team that has an expertise in antimicrobial utilization to be a core part of your program. You have to take action. So we can't just say, we've got a stewardship program, and then you do nothing. So you have to follow through on what you're going to put together. You've got to be out working with your medical staff. There was something called, back in the day, before COVID, we used to do what's called handshake rounds, where we would actually go out and find whether it's the intensive care unit team, the surgical team, and we would actually meet face-to-face with them and talk about some of the patients that they had. We have to then track and report what processes we are working on. Again, kind of going back to the accountability. And then the last one of the core measures is education. So, at least once a month, if not twice a month, I'm looking for opportunities to get in front of whether it's residents, whether it's particular subspecialties, and talking a lot about antibiotic de-escalation, duration of therapy, things like that, which are kind of the core tenets of antimicrobial stewardship. And all of those come into play to kind of help prevent antimicrobial resistance. So those are the 7 core elements that the CDC has rolled out as of 2014.
Great, thank you for that. So what are the new Joint Commission ASP standards? And
yeah, so the original Joint Commission standards were just the 7 core CDC core measures. So before, it was pretty easy to meet them. When you did one, you accomplished the other. But starting January 1st, 2023, the Joint Commission has kind of stepped up their game, so to speak. And so now hospitals are being held to a much higher standard. If I was to kind of summarize so that I don't put everybody to sleep with the specifics of the various Joint Commission requirements, the summary would be advancing your information technology skills. So stewardship programs have to be working with their hospital, have to be working with their electronic health records to advance what the EHR will do for you. As you look at some of the challenges, like with my hospital, we have almost 1,000 patients. I have one pharmacist and I have myself. Now we have other pharmacists that are doing stewardship, like in the ICU when they're making rounds, and we've tried to make sure that all of our clinical pharmacists approach patients from a stewardship standpoint. But you have to have the tools and the technology to make your electronic health record work for you. And so that's one of the things that the Joint Commission is going to be pushing harder on now, is having the IT resources that we need to make our systems work for us. The next kind of core measure or core tenet to the Joint Commission is a multidisciplinary team. So you've got to have nurses, you've got to have your medical staff, you've got to have your pharmacists, you've got to have your infection prevention people involved. And so they're going to expand on that. And then they're really taking the whole guidelines and setting up individual guidelines within your facility is going to be one of the requirements. As a matter of fact, they're getting very specific. They want you to have at least 2 guidelines, and then you have to monitor how well physicians, not just, for example, hospitalists, but how well does Dr. Smith comply with that guideline? How well does Dr. Jones comply with that guideline? And so they're wanting to get very specific into the data. And so there's other things that the Joint Commission is expanding on, but that is kind of a high-level overview of it's either 10 or 12 new requirements that we have now, approximately 4 months to make sure that, kind of do our risk analysis and analyze to see where we have our gaps and where we need to make our changes.
Perfect, thank you. So Dr. Lee, how could a digital tool help support antimicrobial stewardship and some of the things Dr. Burdett mentioned?
Yeah, there are actually a number of ways that digital tools can help support stewardship programs. I think first and foremost, something Dr. Burdett mentioned is that stewardship programs in general have limited resources, limited people power. And we saw this really very evident during the COVID pandemic, where stewardship programs personnel were pulled away to other duties to address the acute issue of the pandemic, but they were therefore pulled away from their normal stewardship duties. So the limited personnel is a challenge, and therefore tools that can help increase workflow efficiency for stewardship programs become very valuable in that context. So one of the core actions of a stewardship program often is prospective audit and feedback, where stewardship programs look at antimicrobial use on a daily basis. And sometimes that can be quite a challenge, because if in a 1,000-bed hospital, you might have half of the population on antibiotics, and you really want to focus on those patients where you're going to get the most bang for your buck in terms of optimization of antibiotics. And so sorting through 500 patients can be very time consuming. And if we can automate that process with digital tools by helping the stewardship team prioritize those patients, flagging certain patients that have high value interventions that could be performed, that is one aspect where a digital tool could be useful. I think another place where digital tools can be useful is in terms of communication and collaboration. There are times when stewardship teams need to communicate with a group of people to socialize a recommendation so that everybody on the team is on the same page about a recommendation. But there's other times where stewardship teams need to communicate one-on-one with a particular individual to really talk about maybe a delicate situation or a more controversial situation. And so communication tools that are flexible, that can allow that type of different types of communication and collaboration can also be very useful. And then I think the third thing that where digital tools can help is in the area of variability in practice. We know that in medicine in general, there's a lot of variation in practice, and that's especially true with antibiotic use. A digital tool can go a long way in terms of helping with some standardization of care. Some of that comes from the ability to generate reports and do analytics where you can look at antibiotic use on different levels, on individual antibiotic levels, on the level of different diagnoses, but also, as Dr. Burdett said, looking at it on the individual practitioner level and being able to generate those reports and to then educate practitioners about their prescribing habits goes a long way towards standardization of practice. And also adding to that is the ability to disseminate guidelines through a digital tool that also allows clinicians at the front line to really be able to access what is considered the standard of care for that hospital in terms of antibiotic use. Giving them access to that allows for a little bit more standardization of care. So I think there are a lot of ways that digital tools can really benefit stewardship programs.
Perfect, thank you. So, Dr. Burdett, what are some new changes and or updates on antimicrobial stewardship programs?
Yeah, so programs are, again, right now with the Joint Commission things we already talked about, that's kind of one of the things they're working on now. There has been, there's some antimicrobial utilization data that is actually uploaded into the NHSN database to where you can do a little bit of hospital comparison, which has a potential role. The challenge is it's very hard to compare yourself, one hospital to another. You know, does a hospital do transplantations, like solid organ transplants? Well, then their antibiotic use is going to be different than a hospital that does not. Do you live in an area of high penetrating trauma? So an inner city hospital or places that have a lot of gunshots or have a very aggressive trauma program, potentially you're going to have different antibiotic utilization. So NHSN data is beneficial from that standpoint to give you, again, a little bit of comparison of how you are utilization-wise to your colleagues. I think, though, the biggest thing that has come from the program standpoint is in 2017, it's hard to believe it's been 5 years, but the Infectious Disease Society of America, IDSA, and if anybody wants to kind of read up more on this, it's idsociety.org. They released their Centers of Excellence program. And so cancer facilities have been centers of excellence. Stroke programs have been centers of excellence. But within the infectious disease world, and specifically within antimicrobial resistance, we've really never recognized hospitals or systems that excel in their attempts to control antimicrobial utilization. And so IDSA rolled this out in 2017. We are now up to 145 centers of excellence. This program is now expanded beyond the United States. It's now, there's a hospital in India which has been recognized. There's other hospitals outside of the United States that have been recognized as doing things above and beyond what the CDC put together. So those core measures that we talked about earlier, to be a centers of excellence, you have to do those, and then you have to do things that are beyond that. And so I think that is a nice kind of designation for hospitals to achieve. It gives you some notoriety. It is a recognition that shows that You are going above and beyond what you need to do to help your patients, prevent antimicrobial resistance, prevent the side effects from antibiotics. There is no benign antibiotic, but yet we need to use them in select cases. And so that is something that programs now can strive for. And the further out that we've gotten since IDSA rolled that out, it has become a more popular recognition for hospitals to seek.
Thank you. Dr. Burdett, what does a day in the life of an antimicrobial stewardship look like?
Yeah, so it varies by physician and pharmacist. So let's talk about from the pharmacy angle first. The pharmacists get in and they begin to look at patients' charts, and that's where you use your electronic health record. You use the digital solutions that you hopefully have, or hopefully you can develop through your IT department if you don't have them at this time. But you identify patients that are either on broad spectrum antibiotics, you identify patients that are on multiple antibiotics, you identify patients who are being treated unnecessarily for urinary tract infection, things like that. And the pharmacist usually comes up with a list of patients that they're going to review with the physician when the team gets together. So in our pharmacy, or in our program, pharmacy does that for a few hours, and then around 10 or 10:30 in the morning, I meet with our pharmacist, our pharmacy residents, any students that we have, and we review those patients. One of the things that I mentioned earlier is that clinical pharmacists have excellent training, they have excellent skills, but they do see things a little differently than I do as a physician. So we meld those together and we decide, this is a patient that we need to reach out to the admitting provider or to the consultant and make a recommendation. So we use secure texting within our electronic health record, and I will send a message to the attending physician and say, your patient came back with a bacteria that was very sensitive to antibiotics. Can we narrow them from a broad spectrum antibiotic to something more narrow spectrum to hopefully minimize, side effects? And so we will just work through those patients, and sometimes the pharmacist will bring a recommendation. And I'm like, yeah, we need to do that, and I'll pass it along to the admitting provider. Sometimes I'll look at a chart and I'll say, what, I think actually in this case, I would keep them on a more broad antibiotic. One of the things that we like to do is we like to have a discussion with the providers that we're sending our recommendations to. We don't just want them to accept our recommendations just point blank. We are not at the bedside of the patient. We have not gotten a history. We are relying on information that is acquired through the chart review. And what you're finding out at the bedside talking to the patient may not be quite accurately, represented. And so we like them to have an open discussion, and then we come to a final decision in terms of the antibiotic use in that patient. So, and then afterwards, I go about my day, and then my pharmacy team will follow up on those recommendations, make sure antibiotics had changed. If the doctor said, yep, that sounds good, we'll narrow the antibiotics. And at 4:00 in the afternoon, that hasn't happened yet, they'll reach back out to the provider. And so, for an antimicrobial stewardship pharmacist, it's pretty much an all-day activity. For the physicians, again, we meet with the team for a couple hours, review as many patients as we can, and then go about our consulting business.
Thank you. Dr. Lee, what are the keys to successful implementation of an ASP program?
Sure, there are a number of keys. I think I'll just highlight the three that I think are maybe the most important. Number one is that I think it's very helpful to have genuine support from hospital administration for your stewardship program. There are a number of hospitals that, as Dr. Burdett mentioned, they're the core elements, and one of them is, hospital support. But a lot of hospitals just kind of check off that box, and give very kind of superficial support for a stewardship program. But for those really successful programs, it's helpful to have an administration that is genuinely supportive, not just on paper, but in terms of effort and passion, where they make stewardship part of really the hospital's quality and safety priorities, part of that priority group. And so that really helps contribute to the robustness of a stewardship program. The second thing I would say is that it's helpful to have a leader that is really very passionate, more than just a leader, but just what I would say is a stewardship champion, that is the head of your program or one of the leaders of your program, someone who is, kind of lives stewardship. It's not just something they do on the side, it's something that they actually believe in very deeply and are able to, spread that passion to other people in the hospital. And then I think the third thing is all about, I'd say, diplomacy. I think historically stewardship programs have been viewed as sort of the antibiotic police, where, perceived as going around and saying, no, you can't use that antibiotic, you can't use that antibiotic, or slapping, someone on the wrist if they do something quote unquote wrong. But I think really the successful stewardship programs are where the stewardship team, I would say, is more like the antibiotic ambassador. They're more diplomats. They're people that go out there and have discussions and collaborate with the different stakeholders in the hospital and work with this mutual respect. Because as Dr. Burdett said, the people at the bedside are the people that know the patient the best. And so the stewardship program has to respect that and has to collaborate with them in a mutually respectful way. And I think that type of diplomacy approach really contributes to the success of a stewardship program.
Thank you. Dr. Burdett, how can a digital ASP tool help achieve the IDSA Center of Excellence?
Yeah, the digital tools are they're an essential for a majority of hospitals. If you are a 10-bed hospital, you may not need digital tools because you can look at all 10 patients. You probably know all 10 patients by name. But, for me, I've got 1,000 beds and I can have 300 to 400 patients a day on antibiotics. And you just cannot manually go through that many patients every day. The other thing about digital tools is, I can look at patients on antibiotic X, Y, or Z, and I can figure that out. But some of the digital tools that are set up right, that are doing bug drug mismatches, that are tracking cultures, doing things like that, will actually help you identify patients who should be on antibiotics and are not. And so it goes both ways. Antimicrobial stewardship at time is actually escalating. So it's increasing the amount of antibiotics. It's making antibiotics more broad. It really is trying to utilize antibiotics for the best benefit of your patient. So it is very hard to know that Mr. Jones 3 months ago had a very resistant E. coli in his urine. You may not be able to go back through that when you're trying to review 300 patients. But with digital tools, you can set them up potentially to pull up old cultures, to identify people who have bug drug mismatches. The computer a digital tool will spit that out at you automatically. But for you to do that manually could be 10, 15, 20 minutes. And you can only do that for so many patients. So the digital tools are really meant to make you more efficient. You can hopefully set them up, or you can set them up to select out things that are important to you. And then you can then access the charts accordingly and get through more patients. To really make an impact in your facility, it's nice to help 1 or 2 patients, but that isn't going to impact antimicrobial resistance and multi-drug resistant pathogens in your hospital. You need to hit a large volume of patients and control antibiotics in a good way in large numbers to impact the flora of your hospital.
How can hospitalists or ER partner with ASP programs for better hospital-based antimicrobial stewardship?
Yeah, one of the things that has been a challenge as we've rolled out our program since 2014 is not everybody is as excited or as interested in controlling antibiotic use and de-escalation of antibiotics as myself and my pharmacist are. And so that goes back to the education, which is part of the core measures. It goes back to demonstrating to them, one, that, as Dr. Lee said, that you're not the antibiotic police, that you really are there to help them take better care of their patient, utilizing your expertise that they do not have. so you've got to make sure they realize that you're not just there to slap their hand and you're not just part of the quality team. You are there to help the patient get on the best antibiotics so that they can get either out of the emergency department or out of the hospital in a very timely manner. And so that's where, again, being collegial, making the handshake rounds, as I mentioned earlier, and again, at times showing them that you're actually going to escalate their antibiotics rather than de-escalate the antibiotics, makes them realize that you're not just there trying to save $1 or you're not just there to try to stop antibiotics. You really are there to help the patient. But in the end, it is the end user, that is going to drive the use of antibiotics, because stewardship programs are a recommending body, but we do not control the antibiotics. We cannot override the admitting doctor. We cannot override what the ER physician decides to do. And so you have to work collegially. And again, we have to do a good job of selling the fact that controlling antibiotics is what is best for the patient. Using a broad spectrum antibiotic for 2 weeks is not needed in most situations. You want to treat as narrow as possible. And by doing that, from a hospitalist standpoint, the patient's less likely to come back in with a complication. From an ER standpoint, they're less likely to come back to the ER because of a side effect from the antibiotic. And we want them all to realize the importance of this, not just for the individual patient, but also for the community.
Perfect. So Dr. Lee, how can residents, ID fellows benefit from learning from or using the digital tools in their training?
Yeah, ID fellows and especially sort of general residents, education of fellows and residents is challenging. I think, medicine is still very much based on an apprenticeship model. So, you learn from who your mentor is at that particular time, and then maybe the mentor changes next week because they've switched service. So you wind up having a lot of different mentors that have different practice styles, different ways of making decisions especially around antibiotics. So for example, one doctor might use, one particular type of antibiotic for urinary tract infection, and then the next week, the resident sees a different doctor use a completely different antibiotic for the same urinary tract infection. And so this is a challenge, I think, for residents and fellows, and it's something that on the one hand they can learn from, in the sense that they learn different styles, and hopefully they incorporate, they eventually learn or grow into their own style, individual style. But at the same time, as I spoke about earlier, this leads to variability in care, and that variability in care often leads to variation in quality of care as well. And so having a tool that provides some base level of standardization, some base recommendations, for example, what would our hospital recommend as the general standard of care for a urinary tract infection? Having that access to information like that can really benefit residents and fellows, especially as they're rotating through different departments and different attendings, and that they're seeing all this variation in practice. So having that baseline kind of standard that they can refer to, and that they can say, okay, this is what's generally recommended. I think there is a lot of benefit in terms of their education, similar to how students in the old days used to carry around a peripheral brain that they would keep in their pocket, and now we can have digital tools that essentially can replace these paper peripheral brains that people used to have. And so I think that that's where a lot of benefit can come in.
Next, we have Alan Antoine, AVP for Clinical Innovation, Care Solutions at Innovator, shows a demo of a digital health ASP solution.
Thank you, Soham. I would like to highlight our two organizations coming together for this collaboration. And we'll also go over our acute infection management system that helps facilitate a seamless technology approach towards antimicrobial stewardship. First, I will highlight that Roche is helping bring the value of clinical science to the table with an integrated solution and portfolio of data-driven and healthcare decision support solutions. Innovacer brings the value of clinical data, a data activation platform that aggregates, normalizes, and activates disparate data from EHRs, labs, claims, pharmacies, and beyond in order to provide healthcare providers with key insights when needed. By doing this with respect to infection management, we hope to help advance best clinical outcomes in antimicrobial stewardship by leveraging technology. The acute infection management system works across all units and all types of infections to help the entire team of clinicians make the most informed diagnosis and treatment decisions possible. It is an antimicrobial decision support tool that looks to better enable the various clinical departments involved in the selection and administration of antibiotics, with the goal of setting and starting antimicrobial stewardship at the bedside. It aims to support the treating teams in following best practice when choosing antibiotics, which will then be sent to the antimicrobial stewardship team, also promoting better communication between the care teams. Now, what does this look like? It may be helpful to see the framework underscoring the multidisciplinary tool that we have built, which essentially starts at the point of care in our EHR integrated solution, where the treating physician would place the antibiotics order directly from the EHR. That order is then reflected in the ASP web tool that gives focus to the workflow of the clinical ID pharmacist. After reviews are completed and updates are made, that is then communicated and reflected back into the EHR integrated app, eliminating the need for entry into two systems, allowing for seamless intervention and communication between treating clinicians and pharmacy. We've also built a reporting tool, which is an all-encompassing administrative solution to assist with creating reports for committees and health organizations, also helping automate NHSN reporting. ASP administrators will be able to review individual hospital and system level analytics and helping establish ASP policy. So in summary, the value is as follows. We understand there's a significant time needed to look through EMRs to see critical patient information, as well as searching for hospital treatment guidelines and antibiograms. So adding value in the sense of triangulating critical data like patient history, allergies, antibiograms, and hospital guidelines into a single view will help physicians make the most accurate antibiotic decisions, increasing patient outcomes. Finding and reviewing patients takes time, especially with the use of multiple tools to detect issues and determine causes. So it is vital to provide seamless workflows to identify antibiotic issues and communicate it to treating teams, which will in turn reduce delays. Time delays, waiting for in-person phone meetings for an intervention are quite common. So we're looking to solve to ensure critical information is passed along by the infectious disease pharmacist to the treating team the moment the problem is detected. And that would ultimately increase the team's response time. Lastly, manual data collection, which is time consuming, does require IT help. Also, real-time ASP performance reporting may not be available. So providing tools where administrators can easily create and automate custom reports will give them time back in their busy schedules. Now, I hope I was able to provide a better understanding into the acute infection management system that Roche and Innovacer have built to provide clinical decision support, focusing on better clinical decision outcomes in infection management and antimicrobial stewardship. Thank you.
Thanks, Alan. So, Dr. Lee, can you elaborate on the antimicrobiogram?
Okay, yeah. The antibiogram is essentially a collection of information produced by the hospital microbiology laboratory that shows, which drugs are various organisms susceptible to, and which might be the best drugs for a particular organism based on susceptibility testing done at that specific hospital. So typically that data is collected annually and compiled into a document that shows that information, and that information is then disseminated to clinicians at the hospital. Oftentimes that's a paper copy, and clinicians may or may not carry it in their hands. So the use of that document sometimes is quite variable. So one of the benefits actually of a digital tool is to actually allow better access to information like antibiograms, so that people can use it at the bedside when they're making empiric antibiotic decisions for their patients.
Thank you. Alan, what type of clinical decision support is provided by the ASP tool?
Thanks, Home. So we're providing clinical decision support in the form of infection management and antimicrobial stewardship. And really the goal is to provide the tools and insights to providers when selecting antibiotics based on suspected infections at the point of care. And those tools and insights are also shared with different care teams, such as the antimicrobial stewardship team, inclusive of the hospitalist, pharmacy, infectious disease teams, really involved in the process of managing patient with infections, and enabling seamless communication when interventions such as escalations, de-escalations, antibiotic comments are needed to take place. So really the goal is to provide these support tools in a manner which remains native to the provider's current workflow, such as being able to access these solutions directly from the EHR or an integrated web application that digests the information from the EHR. Additionally, we provide digital analytics tools for program administrators that would like an overview on specific areas that will give insights to potential gaps in care, system-wide or individual site level, specific when it comes to antibiotic decision support, and it also aids with NHSN reporting.
Thanks, Alan. Dr. Lee, what should we look for in a digital tool for an ASP program?
Well, I think what one should look for is somewhat dependent on the specific stewardship program and their needs. However, generally speaking, I would say that when looking at a digital tool, one should really look for a tool that was specifically designed for stewardship programs. There are a number of tools out there already that were initially designed maybe for infection prevention reasons or for pharmacy workflows, and then they sort of pivoted and used those tools and applied them in the stewardship space, but the tools were not originally designed specifically for stewardship. So I think looking for a tool that was actually primarily designed for stewardship is one thing that should be looked at. I think the second thing is that stewardship programs, because each stewardship program has its own priorities and needs, to some degree, the tool should be customizable. So there should be features within the tool that allow customization so that the stewardship program can really act on their specific priorities, whether that could be related to certain flags that are created. So flags for things like bug-drug mismatches, or flags that alert the stewardship team about use of specific target drugs that are important for that stewardship team. That customization is important. I think I would also say that the customization is important also for the reporting tool. So when the stewardship program needs to create reports about antibiotic use, sometimes that needs to be customized based on, again, on the priority of that stewardship program. And historically, what's happened is that those types of customized reports are very difficult to get and require a lot of support from your IT department, and sometimes they don't have the resources to provide that support for the stewardship program. So if the digital tool allows that customization to happen without the need to tap into your IT support, that is something that's very, very valuable for a stewardship program. And then I think the last thing I would just mention is that a tool that also not only helps the stewardship program in their daily workflow, but also brings some of that stewardship to the bedside clinicians who are making the decisions about antibiotic use up front for their patients. If that tool, the digital tool, actually has a component for the bedside clinicians so that they can access information that it helps them with those first antibiotic doses, whether that be access to the antibiogram or access to clinical guidelines, that is another valuable feature for a digital tool.
Thank you, Dr. Lee. Dr. Burdett, what should a hospital focus on to be an IDSA Center for Excellence?
Yeah, so to be a COE, you need to meet the CDC core measures, but that just because you do what's required, that's kind of like the floor. That does not make you a center of excellence. You need to go above and beyond um, what is required. So what I usually recommend when I'm asked this is, you need to have something in place that one identifies your local issues. You need to know your facility. Some facilities have issues with overtreatment of UTIs, others have issues with overtreatment of pneumonia. So you need to know your issue. Two, you should come up with a process that looks at not just the antibiotic utilization, but also look at it from a diagnostics standpoint. So, do you have a radiologist or radiology department that calls every abnormal chest x-ray a pneumonia? Well, then you need to work on it from a diagnostic standpoint, work with your radiologist to figure out how you can what better terminology can they use to not stimulate the desire to treat pneumonia based on an imaging. So you should have a diagnostic stewardship component, and then you should have an antibiotic stewardship component. And then you need to be able to track your outcomes, whether that's tracking ideally through utilizing your information technology, your IT department, or whether you have to do things another way. But you really should have a program or a initiative, might be a better term, that identifies an issue, attacks it from the diagnostic standpoint, attacks it from the antibiotic standpoint, and then monitors to see what kind of response that you had. So, for example, one of the things that we've done this year is we're working on gram-negative bacteremia. So we worked on bringing in some new technology to more rapidly identify the bacteria. And then we worked with the doctors. Literature now is very clear that 7 days for most uncomplicated bacteremias is enough when it comes to gram-negatives. So we identified that our average course of duration was almost 14 days. And that was whether it was infectious disease doc or the non-infectious disease docs. And then we are now educating and we are rolling out and monitoring whether we have cut our duration. And so that's kind of one of the examples. And the last thing I would say to really be a COE is you have to hold the ID doctors accountable. Just because I am an infectious disease specialist does not automatically make me an antimicrobial steward. There are some infectious disease docs who actually are kind of the antithesis of a steward. So holding your ER doc, holding your hospitalist, and then holding your infectious disease colleagues accountable for their treatments and their outcomes all goes into kind of making yourself stand out and be unique as a center of excellence.
Thank you, Dr. Burdett. Dr. Burdett, one more question for you. It looks like from Timothy. With these new standards, is it beneficial for hospitals to offer an at-home surgical wound infection program to reduce post-surgical wound complications?
Yeah, I mean, that falls a little bit more under the infection prevention angle. They are, like, for example, we have utilized our home care team to be much more involved with home nursing, to try to minimize any complications, to make sure the patients are doing appropriate wound care and all that kind of stuff. And so I am a big believer in that. Again, we drive ours through the home care. There's probably some ways that you could do it through telemedicine with home visits, where the provider is just sitting in their office and talking to the patients. But yeah, I do think that's really where things are going, especially as we try to get patients out of the hospital in a more quickly and efficient manner. That does put a little bit more of an onus on them. So yes, I do think that taking advantage of home care facilities and home care resources is critical to decreasing the rates of surgical site infections.
Perfect, thank you. There was another question about slides. We will be sending out an ebook after this call to every participant on this call. Alan, any closing remarks from you?
No, well, thank you, everyone. Thank you, Soham. Thank you, Dr. Burdett and Dr. Lee. I do believe that it was a very fruitful discussion, especially in the realm of really having and utilizing digital tools to really enhance the antimicrobial stewardship practice and infection management. And so if there are any questions that come from this with regard to the presentation that you may have seen from my end with regard to the actual clinical workflow and the tools that we are building, please feel free to reach out to me, and would definitely welcome more discussion and a demonstration after this.
Thanks, Alan. Yeah, thank you everybody for joining. Like I said, you will be receiving an ebook following this webinar with supplemental information. If you'd like to see a product demo, please reach out to Alan, Antoine, or Jessica Fowler. Their emails will be in the ebook that's going to be sent out. If there are no more questions, once again, thanks everybody for joining.
Well, I'd like to thank everyone in our audience for attending this Fierce Healthcare webinar and for submitting so many great questions. I'd like to thank all of our speakers for participating and Roche and Innovacer for presenting today's webinar. This webinar has been recorded, and you will be able to access that recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.